accountant. Very bright lady, very well read. You'd probably give her, she'd probably passed the national training Vivas. She knew that much about salivary tumours. So she comes to my clinic, 6 months history of painless neck lump, which is, there's an arrow pointing to it, but just in case, it's there. Yeah. So what would you do with her?
So seeing her in clinic, start off with getting a full history about the lump. I'd want to know, it's been there for 6 months, has it been growing in that time? Did it come up suddenly and then has it stayed static?
Growing slowly growing. No other relevant past medical history. She's a non-smoker.
And is it painful at all?
No, painless. It's painless.
I'd want to know if she noticed any weakness or symptoms around her facial muscles, whether she's any numbness around her ear or her temple, that sort of area, and whether she's had any problems, sort of general upper area digestive tract symptoms that might indicate anything pressing through on the other side.
Nothing else.
And looking at it there, it does look as though it's in the lower parotid region. In the absence of past medical history or any other drug history that she may have. In the absence of any parotid history, I'd go on and get some investigations done.
What would you get?
So I get an ultrasound scan with, and our radiologist would do an FNAC if they wanted to as well.
So I'll just stop you there. So in the audience, how many people here, so that's a parotid lump, how many people here would do an ultrasound, FNA, or how many of you would stick a needle in clinic then and there? Who would do the FNA in clinic? All right. And the rest of you, would you do an ultrasound guided FNA? So it's kind of half-half. Nick, would you put an FNA in clinic or would you do an ultrasound?
So all the literature supports the accuracy improvement with using an ultrasound scan. And you're likely to get an ultrasound scan anyway. And as it happens, I am fortunate in the sense I've got a one-stop clinic with an ultrasonographer doing.
But not everyone has that.
No, I get that. And just talking about South Africa before, Johan Fagan makes the point that he does them in clinic and feels that that's a reasonable alternative. Yeah. It just depends on what facility you've got. So if you haven't got an ultrasonographer in clinic and you can get an FNA done there and there, there's not a problem. Just that your adequacy rate may not be quite as high.
Shane?
We used to do them freehand, and we used to use cores as well freehand. We did a study, we did a local survey, we got 40% hit rate. We did that as a preemptive getting a business case for getting an ultrasound machine for a radiologist to come down and do a clinic. That all fell apart as the radiologist moved, so I started doing it myself. Got trained to do it, so I do them all myself. I run an ultrasound clinic. You learn a lot about these lumps from doing the ultrasound yourself. I do cores, 18 or 20 gauge when I can. Always use local anaesthetic. Hit rate's about 94%.
So
could I just make one other point, Sanjay, on this? It is important, is that one of the things about adequacy is actually having a pathologist or a laboratory officer looking at adequacy for you at the time. Yeah. And so one of the things that skews any audit that you might do on these things is the fact that there is an improvement in adequacy often because when we do the ultrasound scan and get cytology with somebody there looking at adequacy, then if it's not right, they go and do it again. Whereas in a clinic, there's not often somebody there to look at adequacy. So one of the key things is actually having somebody there to look at adequacy. If you're doing it freehand, it's just somebody there just to check and go, actually, there's some cells there to look at. Or if you've been trained in it yourself to look at adequacy.
Yeah. So I think if you're sitting the exam, you'd be very safe to say an ultrasound guided FNA if that's available. You can do freehand FNA. I don't think you'd be criticised, but literature would suggest the ultrasound, as Mr. Roland says, gives you a lot more information about the characteristic of the lump as well, and the hit rate, if you like, is a bit higher. So I think the model answer, if you've got all facilities, would be an ultrasound guided FNA. So back to you, Neil. The FNA suggests a PSA, pleomorphic salivary adenoma. What would you do next?
So I think this lady's got benign tumour for her parotid gland. The ultrasound didn't suggest any other suspicious features. And it's a benign tumour that has got malignant potential, and she's young. She's hopefully got a long time to live. So I'd have a discussion with her. I'd explain about the diagnosis, the potential risk of malignant change over the forthcoming years and decades, and also that certainly in our department, I think most places we'd recommend excision of this lesion.
Would you do any other investigations?
If I'm operating them, I'd do an MRI scan.
Okay. So would Nick and Shane, would you both do MRIs?
I don't always get MRIs. If I, just as Nick suggested earlier, if you feel it's a small, mobile, superficial lesion, I won't. But increasingly I do. And certainly I will if there's anything on the cytology that says there's dysplasia or uncertainty.
No, it's a PSA,
I'll
though.
definitely do that. Sometimes you get PSAs and say there may be some dysplasia, but not always. But
Nick, would you get
increasingly.
an MRI?
So if the ultrasound scan suggests there's deep lobe involvement, then I'm going to get an MRI. I want to get cross-sectional imaging.
So how many of the audience would get an MRI? Yeah, majority. So I always get MRIs now. Just that I think over the years you occasionally get caught out. And it's okay, we're all trained to do it. But there are definite times where you think it's going to be superficial and it's gone into deep lobe. And I think that impacts on your consent for facial nerve neuropraxia.
I think if they've had an ultrasound and it's shown to be on the ultrasound in the superficial lobe, I think you could say,
okay,
that's okay.
So treatment options. So Neil, you're talking about surgery. So I'd agree. So we listed it for partial parotidectomy. Nick, you gave a very nice talk today in the overview. But in terms of consent specific to this lady, she's 28, very well read. It's a 6 centimetres, a good size pleo. And she was very keen on talking about the facial nerve. What risk in terms of percentages, what would you say to them if they pushed you on what are the real chances of me getting a facial nerve palsy?
So the risks of a temporary, because obviously we're going to talk about temporary and permanent facial nerve palsy, the risk of a temporary facial nerve palsy are considerable. And you know, if I was pushed on it and just to give a rule of thumb, I would say that, you know, there's a 50-50 chance of there being a facial nerve palsy. Now, the literature would suggest a range from, you know, 15-20% to 50%. But the reality is that the patient needs to know that there's a considerable risk of a temporary palsy.
Yeah. Shane?
I document a figure. I say, I talk about 15%. I say 1 in 7 risk of a facial palsy, and that's backed up by our local data. And I say less than 1% of that being permanent. Okay. That's just for facial palsy.
Okay. Yep. So I've talked about the facial nerve monitor. Okay. So she was very keen on this. Yes.
Just interject. There is a leaflet that is sponsored by the Royal College of Surgeons at the moment, and AIDO Healthcare, which is trialed in some of the trusts now. But one specific about parotidectomy actually mentions the risk of injury to the facial nerve of 1 to 1,000, which I think is much lower than the... Yeah.
Okay, so that's probably just a superficial parotidectomy or hemisuperficial parotidectomy. That's a deep lobe tumour, so it's a different beast. Was deep lobe tumour, wasn't it, that we were talking about? Yeah. And so I think your figures were quite...
No, that was superficial. Was it deep lobe? Was it 6 centimetres into the deep lobe?
Yeah.
Oh, well,
that's
quite
why we did an MRI.
Higher figure than... sorry, no, that was superficial. I would quote a 50%.
But the question is that
1 to 2%
on this leaflet from the Royal College, it's 1 in 1,000 is the quote. That's not correct.
No.
That's just not correct, even in the best hands, I would say.
Yeah.
1 in 1,000 is not correct.
Is that all parotid surgery? Does that include...
It doesn't specify how big or small. So it's just a leaflet sponsored
I think that's wrong.
Royal College that says parotidectomy.
ENT UK leaflet doesn't say that.
That's interesting. The Royal College would form a leaflet without involving us.
It's a new one with more colours and more informative.
Is it a permanent policy or a...
It doesn't specify as well temporary or permanent.
That's colourful but crap. So basically, I think permanent palsy, you'd go with around 1%. I think that's reasonable. And temporary palsy in a superficial parotidectomy up to about 5%, but most figures are around 2 or 3. But for a deep lobe tumour, the take-home message is that all bets are off. You know, they can get a temporary palsy, up to half of them can get a temporary palsy, maybe slightly less, but you know, you need to tell the patient that, look, there's a significant risk of a temporary palsy. A permanent palsy is less, but nevertheless, the risk is higher if you're doing a deep lobe tumour.
So she was very keen on the facial nerve monitor. She knew all about this. She asked me, do I use it? I said, yes. So in a way that she was reassured about that. So, an interesting question. Let's say you're halfway through this surgery now, and the facial nerve monitor stops working. Neil, does that have any effect on you? Well, sorry, let me just change the question a bit. Let's say she's asleep, you're about to start the operation, you're putting the electrodes in, and the facial nerve monitor is not working. So you have not made a skin incision yet, but she's asleep. Would you proceed or would you abandon?
So that's a difficult one. I use a facial nerve monitor for all of my prostatectomies, and that's not consistent with my unit. About half of us do, half of us don't. Right. I don't use it to find the nerve. I use it as a testing thing at the end. I think knowing that you've got a deep lobe tumour and knowing that I always use it, I think I would struggle to defend myself knowing pre-incision that something wasn't going on. I won't necessarily wake the patient up. I'll use the fact we've got a few monitors in our department to say I'll get another one going. But and if you'd push me as to if they're all broken, I don't know. But no, I would, given what my practice is, and this is a deep lobe tumour with a significant risk of facial nerve injury, especially with the title of that slide coming up, then I'd want to work in monitor for it.
Nick, what would you do?
So I've got to confess, I'd probably crack on.
You'd crack on. I think you say that every year.
Yeah, so I mean, I obviously use a facial nerve monitor, but against, all of that, the risks of anaesthetic, I've got a patient asleep. I've been taking them out for many years with or without a monitor. It's going to be about, I don't think any of us use the monitor to find the nerve. It's just an indicator if we're close to the nerve. But a facial nerve stimulator, which may also be available, may help us in that respect as well. So it's just one of those risk-benefit ratios. And there's no right and wrong answer to this, is there?
No, that's why I've put it. Shane, what would you do?
I don't use a monitor. I have a stimulator, but I don't routinely use a monitor. I think if you've told the patient specifically you were going to use a monitor, and you've had that discussion and you haven't done an incision, I probably wouldn't do it. I'd stop. If you're halfway through the procedure, it's different because the risks of going back in on the nerve are much higher. But I think if you haven't made an incision and the monitor, and it's been a specific thing, I would stop.
Okay, so I'd agree with all those points. I think if you're halfway through, you've got to carry on. If it's not working at the beginning, it depends on the consultation you've had with the patient. In the States, last year, I think there was a paper out. So the surgeons there would just not continue if the monitor's not working because they're so medico-legally minded, which is interesting. Okay, so halfway through this case, and I find the buccal branch is really stuck on. So there's a big tumour, and I'm not confident that I can pull it around. You normally can, but there's times you just think, the tumour's too big. Should the buccal branch be sacrificed, Neil, to get it out?
And this is a working. You say the nerve monitor stopped working, or that branch has stopped stimulating as I've been. So it stopped stimulating as I've been dissected.
Let's just say the nerve monitor's not working.
Okay.
You've got the buccal branch plastered onto the middle of this 6 centimetre tumour, struggling to mobilise it enough to get the tumour out. Would you cut the buccal branch? Does it matter if they lose the buccal branch?
I think they all matter. I think that the concept of the overlapping branches in the facial nerve is obviously important, and as we said, it can give you a bit of reassurance if you get stimulation from the other branches. But I also think there's a lot of the interplay between the branches is what gives a lot of the subtleties of facial expression, so that the particular look that someone gives in a situation. So I'd never be blasé even about cutting a small branch, even if there does seem to be overlap. But if it was completely plastered on and I couldn't get off without breaching the tumour, then I'd sacrifice it.
Okay, so we managed to mobilise it, but you get to a point sometimes where you've mobilised the nerve so much you just think there's no blood supply to this, it's just a little thin thing, is it really going to work? But the idea is to try and preserve it if you can. So, something that happens actually from time to time, final histology, she does well, there's no facial nerve palsy, everything's gone fine, goes home the next day. So the final histology, however, shows actinic cell carcinoma, which is, it does happen particularly if it's a low-grade actinic cell, often mimics a PSA. So, completely excised, but you can see from the previous slide, you're bound to have a close margin, just by the way the facial nerve is on that tumour. Bernie, does the patient need any further treatment, do you think?
She certainly warrants a discussion about it. I mean, take into account she's young, so the risk of radiation-induced malignancies is there as well. But I think it has to be balanced against the fact that she has a positive margin on the facial nerve. Yeah. And so if we do nothing, it might not happen quickly, but this is likely to regrow and cause facial nerve paralysis. So I very much would be sort of trying to sell her that she should have adjuvant radiotherapy.
But would you be asking your surgeon, the NDT, to go back in? Because she's had a partial prostatectomy and clear the rest of the parotid out.
Yeah, well, potentially, but I suppose it depends upon, are you going to better that margin and have you taken away the most of the tumour? Because I think even if, if you've taken away the lump of tumour and it's simply that positive margin, then I would obviously, defer to your expertise in terms of, is that going to improve the outcome? But she's still going to need radiotherapy. So I suppose that's the question that needs to be answered.
So Shane, you're an expert at retrograde facial nerve identification. Would you go back in?
I looked at this question for the EBM day in November that we had on salivary malignancy. Yeah. I did a literature review on it.
Yeah, no, I realised that.
And there's no evidence to suggest you should go back in, because we used to. That used to be our departmental policy. It used to be part of the discussion. So that's off the table. And all the evidence suggests that even if it's tumour on the nerve, that's still an involved margin and the patient needs radiotherapy.
Yeah, so you wouldn't go back in?
Definitely not.
Okay, so that's answered that. Okay, second case, just to move things along, because I realise it's been a long day. So a 52-year-old gentleman, slow-growing tumour, located in the inferior part of the gland, and the FNA is consistent with either a low-grade tumour or a PSA. Had 2 FNAs, both by an expert pathologist. Okay, so it's either low-grade tumour or a PSA. So we then decided to go on for core biopsy and ultrasound control, still unclear, either a PSA low-grade malignant tumour. So we've had 2 FNAs, core biopsy with an ultrasound, and a good pathologist. So Nick, what should we do next? Well, first of all, why is it so difficult for them to find out, do you think? The pathologist, why do they struggle with salivary gland tumours, the pathologists?
So, I mean, it's because of the diverse nature and because they look like each other. Yeah. And they're just looking at cells. Yeah. I often say that, looking at histopathology or gross histopathology is like looking at countries, and looking at the cells is like looking at faces and trying to recognise, where they might be from. You've obviously done a core biopsy on this particular case, and after that, really, you're just having a discussion about excision, aren't you?
Yeah. So you may remember the slide that Mr. Roland puts up with the WHO classification. There's loads of salivary tumours. It's actually very difficult. You do need an expert pathologist. So something controversial, something I do. We've audited at our unit, works well. Randall Morton wasn't very happy with me for doing this, doesn't believe in this. What do you guys think about frozen sections in salivary surgery? Nick?
So, I hate frozen sections because the problem is, first of all, they're not going to tell you a definitive diagnosis. They may tell you that there's a malignancy of some form, so it's useful.
Correct.
The second issue with, and peculiar to salivary gland tumours, I think, is you're going to breach the capsule sometimes, or you may breach the capsule to give them some sort of specimen. The third thing is that I just want to crack on with the list and not wait for frozen sections.
That's the real reason we know.
It's the real reason.
Just impatience.
So yeah, it's
so just to be clear, when we do frozen sections, we don't breach the capsule.
No.
We take the whole lot out and sell them the whole lot off,
sure.
and they slice it in the labs.
Sure. Yeah. But there are those issues, aren't there, around it, that you've got to crack on, do the procedure, or take a piece, and you've got to send the thing off, etc., and send it off to the pathologist. The main issue then is that the pathologist often won't call it. Yeah. So it's a bit like cytology. They just won't call whether they think it's malignant or not. And I know the debate goes on. There are some cases where it may be, pivotal importance that there and then on the table. But for the most part, it doesn't really change what you've had to do. Most of us are going to do a superficial prostatectomy for a superficial tumour. And, unless there's compelling evidence that you need to do a neck dissection, we're not going to do a neck dissection. If we know it's malignant, that's different.
So frozen section is controversial. There's evidence coming out more and more that some units are using it and it's fine. Depends on your pathologist. What you really want to know is it malignant or not. If it's malignant, I personally then do a total conservative prostatectomy with a net dissection, so it's done. And if they come back and say it's benign, I do superficial and get out. Neil, what's your view on frozen section?
So if we had the availability to have it like that, I'd do what you did. We have continual struggles with our pathology team who, through a combination of resources and lack of will, mainly resources, will say we find it difficult to get. We find it difficult to regularly get frozen sections done. But so I do what Nick would do for superficial lesion, do a superficial prostatectomy. But certainly if I had it regularly and easily and efficiently available, then I'd probably go down your line.
Okay. So
I think here is that with it being either a low grade or a PSA, if you can just make sure you've got a margin all the way around, well, actually, that could be your treatment anyway. A low grade tumour with a good margin.
I agree.
That's your treatment.
That's what I'm saying. That's what you're going to do.
But what I feel is that if there's uncertainty on the FNM core, and this is what happened. So here we are. It's a mucoepidermoid tumour. So that was what the frozen section said. So that changes the things, doesn't it? So now you've got this result back. What would you do? So you've done a partial prostatectomy so far. It's mucoepidermoid. Would you do further surgery, Shane, intraoperatively?
It would depend where the lesion was in the if it's sitting right on the top at the front and you've got a big cuff of tumour around the outside anyway, and your closest margin is going to be the skin. I'm not going to resect the skin at that point to get a thick, a lateral margin. But if it's in the body of the body of the parotid, and you think, well, I'm close here, then I would go to a total prostatectomy.
Nick, would you do a total if you knew if it was a mucoepidermoid?
It depends on what kind of margin I had around it. But
what about the neck?
So we're going to do a neck dissection for a mucoepidermoid.
Okay, so that's what I did. I actually did a total conservative and selected neck. And the final histology was high-grade mucoepidermoid carcinoma. So, Neil, what do we mean by high-grade? What features make a tumour high-grade? It's something you should probably know for the exam. They might ask you about high-grade, low-grade. So
Things like number of mitoses that are present within the on the specimen within the tumour itself, a degree of de-differentiation within the carcinoma, so more de-differentiated tumours generally are worse and considered more high-grade. You'd be pushing me to get many other histological features at this stage.
And there's also neurovascular.
The perineural and lymphovascular invasion.
Yeah. So, and does it correlate with clinical outcomes always?
Yes, I think it does.
I think for mucoepidermoid it is useful, but in the others not necessarily. So you can get low-grade tumours in the other pathologies misbehaving. Yeah. So it's not always a given, but I think in mucoepidermoid of all of them, it's probably the one that perhaps correlates. Okay, third case. So this is one of our hospital porters who came to see me last year, actually. 12-month history of a sensation of a lump in his throat, and he'd noticed a change to his voice. And nasendoscopy showed a normal larynx and hypopharynx. He's a smoker. No other relevant past medical history. He's not taking any medications. All right. So there's an intraoral examination. What can you make that out, Shane? Can you see what?
Has he got a pharyngeal displacement or uvula displacement? So something parapharyngeal.
Parapharyngeal. Okay. So always look in the mouth with these patients. Nothing to palpate externally at all. It's all intraoral. Okay. So Shane, you gave a nice talk on this today. How would you get histology and cytology? I'm presuming you would want to get histology and cytology.
I'd scan them. I'd do an MR and first, possibly CT as well. Yeah. And depending on the vascularity, I'd usually be quite happy to go for a transpalatal true cut.
Yeah. Would you do transpalatal, Nick?
Yeah, I wouldn't have a major issue now, but the old concern was that you're going to go into a vascular lesion and have some fun,
or spill pleomorphic cells everywhere. Yeah. But I think now I don't think that's Neil. Would you be happy to go?
Yeah, we do a transpalatal after cross-sectional imaging.
Yeah. Okay. So there's an MRI scan. So Neil, staying with you, what can you see there?
There's a large parapharyngeal space lesion on the left-hand side. I'm not sure if those are flow voids within it from here. and
Steady.
yeah, obviously encroaching very far medially over. I don't think on that actual image it's coming off the deep lobe of the parotid, but again, can't fully see from here. So parapharyngeal space tumour.
It's a big tumour though.
Yeah.
Yeah. Okay. So if I told you that the FNA showed pleomorphic salivary adenoma, okay. If I tell you it's a PSA, it's quite big. What is the treatment? What do you do?
So again, we would say, how old was this? Is a
55.
Otherwise, well, so we'd say it would need to come out, and then it would be discussion about how we'd get that out. I don't have any experience with robotic work. That would seem to me to be quite big to take out robotically. But I mean, we'd probably get an opinion for that. But sorry,
Might look at a combined.
But in our unit, without that, we'd be doing a joint surgery with the MaxFax team.
You did join it with the MaxFax, would you?
If we were having to split the jaw to get to that.
Nick, what would you do? Do you think you need to split the jaw for that?
So most of these, I don't split the jaw. I never do split the jaw. I split the jaw. I think that some people would debate whether you can take that up perorally and through the oropharynx. I think is the debate to be had, and the issues
and that would be
issues with that.
That's what I speak to you saying earlier. So with the robotics, there are people doing parapharyngeal deep lobe tumours through transoral using a robot, aren't there?
Yeah, there are a small series coming out which
There's a high
suggests that it is
spillage rate.
safe now. Well, it depends on the centre you look at. There's a series coming out of Philadelphia, I think, which said they did about 50 of them, and they were totally safe. They didn't find there was any higher spillage rate than transcervical. We haven't got a lot of experience of doing it that way, but I'd start considering it in the future because we've got more robotic experience now. Traditionally, you've taken out transcervically.
Okay, so I've done quite a few of these now. Actually, just happens to have got them that sort of size. I've never had to split the jaw. I've taken the submandibular gland out, as you showed in your slides, sometimes just for a bit more access. But you can normally get them out to the neck. But I think it's prudent to have a maxillofacial surgeon available to split the jaw, if that's what's required. So here we have it. This was this tumour, 8 centimetres. If you look at this area just here, so this is where I've basically gone around with the finger, as you do, swooped it out. And on the final histology, so that area of the capsule has been breached. All right. Otherwise, it looks fairly intact, really. Do you think it needs further management? Do you think it needs anything else doing, just for a breach of the capsule?
Where was that breach? Is it orientated?
There. It's in the deep parts where I've perhaps caught it with my glove as I've used the finger to deliver it. But the rest of it, you can see that. So this area here would be the bit that's most lateral.
Yes, okay. So I think based on that then, because the reason why we offer adjuvant radiotherapy in the pleomorphic salivary adenomas is when there's this risk of the facial nerve and where, as surgeons, you really don't want to go back in if we can avoid that. So I think this is a special case and I wouldn't be rushing in to give it adjuvant treatment.
Do any of you guys think needs anything doing extra?
I haven't really sold it to us. I mean, there's a difference here about breaching the capsule or a denuded parts of the capsule. There's lots of bare areas of capsule that can occur. That didn't look like there was an incomplete
No, I don't think it was a
excision,
frank burst.
and it didn't look like there was a spillage.
No.
So my threshold for radiotherapy, there's a high one. I wouldn't be thinking to give radiotherapy really.
So
I'd have the discussion in the MDT to document we thought about it, but I think we'd end up saying no.
And also offer the patient the opportunity to come and discuss it with a clinical oncologist if they wish, but I would not be wanting to irradiate it.
What if I had been more candida and had burst it? Then what do we do?
I think this is where it's that discussion in the MDT, isn't it? And so very much I would rely on you as a surgeon to say, what are your concerns?
Well, if I said the capsule has been frankly burst and I think I've spilt it, and I've spilt it in the parapharyngeal, the deep area, which if it recurs, as you guys know, is a bit of a nightmare to go back into.
Well, first thing you do, I mean, you've said what you do during surgery, dissection, so the first thing you do is you actually wash it all out.
Wash it out,
He's
55. He's 55.
Yeah.
What would you do, Neil, if you burst it through surgery? In the deep part, so we've burst the tumour in the parapharyngeal space through surgery. We've done what Mr. Roland suggested, thoroughly washed it out, taken it all out. It's all benign.
I think for Frank, if it was frankly burst and spilt, even with an immediate washout, which whether that I don't know what you wash out with, which is I suppose another question. But we'd be discussing that in the MDT as to whether we'd potentially be more likely to offer radiotherapy for that case.
So I wash out with water, a tumoricidal water, and even more tumoricidal iodine solution.
Is it
that really kills everything off, I find. But in all seriousness, afterwards, I mean, spillage is a relative indication for radiotherapy.
Yeah.
So the case is getting stronger.
Yes.
It's not quite as bad as incomplete excision, but the case is getting stronger now for radiotherapy. And again, there'll be a discussion, wouldn't there, in the MDT?
And then seeing the patient.
I think you tell the patient what's going on. You tell them no one knows, because there is equipoise here. No one knows what the best thing to do is. You give them the case for both, and you help. Yes, the patient may say, I don't know, you tell me what's best, but you say, you can either have radiotherapy, here's the side effects of that, there's a chance it's going to give you less chances of recurrence in the future, it could be a problem, or you may never get recurrence, and if you choose not to have radiotherapy, and it does happen, we have to deal with it at that point. Document that discussion as well.
What would be an interesting question is of us and the audience, and having Bernie's excellent talk.
Can I say something before you say that?
Yeah, you know what I'm going to say.
You should not have the discussion with the patient about the radiotherapy. The patient deserves the opportunity to come and see a clinical oncologist. Because I've heard some incredible stories that patients have been told about what's going to happen with radiotherapy, and it simply has changed an awful lot. So please, what I would urge you is to say you should go and see my clinical oncology colleague, because we've discussed you in our meeting, and there are pros and cons for considering treatment. And
all of our patients see the oncologist with the surgeon at the same time. We are seated next to each other every time.
I was just going to say, for the first scenario where you've got the tumour out and there's possibly a bare area of capsule, how many people here would want to have post-operative radiotherapy?
If this happened to you, how many of you wouldn't want to have radiotherapy? So seats.
So this is just a bare bit of capsule.
The first scenario.
First scenario.
Yeah.
One person. Okay. There's a morbidity with the radiotherapy as okay.
But that shows us we have to tell the patients, and because the patients will choose different things.
How many of you would have radiotherapy given the situation where there is spillage? More of you.
And what dose radiotherapy for spillage would you give then?
So for pleomorphic salivary adenoma, we do tend to use a slightly lower dose than we do for squamous cell carcinomas, so typically in the range of between 54 and 57 gray, again in 2 gray per fraction, but obviously just treating the tumour bed in the area at risk, not the neck.
Not the neck.
Yeah.
Okay, so anyway, he didn't have radiotherapy because it was only a slight scuff of the capsule, so it hadn't burst it. But a 6-month review, he complains of pain on biting at the start of a meal. So, do you know what that is? What do we call that? First bite. Okay. So, Neil, how do you treat first bite?
It's difficult. It's a real problem when they get it. So, usual warnings about eating. So often it's the surprise that gets them as well. So once they've got it established, they start using other compensatory mechanisms to try and get it. They can then get problems with their TMJ, they can get problems surrounding it. So understanding of what's going on for them. Neuralgic type painkillers can have some help. Local anaesthetic injection can have some help. We run a dedicated facial pain clinic who see patients with first bite syndrome as well. And that's a sort of pain consultant, ENT, MaxFax coordinated group that are happy to see any patients that have this. But it's difficult.
What's the natural history of it? Shane, what would you tell your patients? What can they expect?
The other treatment we use is Botox. Yeah, we use Botox and get quite good results from it.
Do you?
Yeah, and but it can often be delayed. It can come along. It's variable for different people. Some people it doesn't really bother them. Some people it peaks and then wanes as they either get used to it. But some people are.
So the literature would suggest typically 2 years, and then it starts to settle down. Some people give gabapentin, things like that, and then there's Botox. Okay, he also is another complication I've had. It's been a great day. Complains of redness, heat, and moisture on his face after he's eating. Yeah. This isn't him, by the way. So what's the pathophysiology of frays, Nick? Do you know why do patients get frays?
So it's just the parasympathetic fibres growing into the skin, and they get gustatory sweating.
Yeah. Okay. How common is it?
It's very common. Just don't ask about it.
Yeah. So it's actually very common, much more common than people think. And actually, back to your talk, Nick, where you talked about a thick skin flap. It's one of the mechanisms to reduce frays. What about surgically? Any other techniques? Neil, do you use any techniques? So actually, I did use a technique on the first lady, the 28-year-old, the big lump, because she was going to get a cosmetic defect as well after that, and she's young. What do you do? Any intraoperative?
So we heard earlier about if you're doing extracapsular dissection, replacing back down the open parotid that you've done. Certainly, if you've done a superficial and you've got an area that can be covered down. I don't know that there's any good evidence for using things like Tacosil or barrier instigator between the cut surface and the skin that can help, but that's something I know that some people use. I don't.
And some fat people have used adipose tissue as they have the first bite syndrome. Putting some adipose tissue in, and some people have used muscular flaps to help.
So I sometimes swing a sternomastoid flap across just for the cosmetic defect, and also as a barrier to reduce the risk of frays.
I'll do the same for people who are particularly concerned about that. There's a paper in Operative Techniques in Otolaryngology, Head and Neck Surgery this month on the vascular supply to the SCM flap, if people are interested in that. And some people say a subsmass dissection is useful for this as well. Keeps a full layer intact.
So Shane, staying with you, what are the treatment options for frays? Let's see it is bothering him. So it affects a large number of patients with prostatectomy. Less than 5% it will bother. Okay, so let's say it's bothering him a lot.
So if you test it, if you do Miner's test, 50%.
So there we go.
Test.
So does anybody here know what Miner's starch iodine test is?
Starch iodine.
No, but do you know how it works? I mean, I want to know if any of them know how it works. No? Do you want to just tell them how you do that then?
You dust the face, you paint the face with iodine and let it dry, then dust it with starch, and then you give them something, a sialagogue, and when they sweat, it dissolves it eats the, it enables the iodine to be dissolved and mixes with the starch, and you get a colourful reaction.
Yeah. Okay. So would you all agree to use Botox for frays?
Yep, definitely.
Yeah. So you do the Miner's starch iodine test, which tells you the area that's sweating, and then you can draw up 1 centimetre cubed areas, and you can put 2.5 units per cube of Botox. And it works well. You have to repeat it sometimes after 6 or 12 months. I've had quite good results with it. It's been quite good. I don't bother even telling them about using antiperspirants and that anymore, because none of them like doing that.
I had someone just yesterday who did not want Botox, and so I told them about aluminium chloride
They're right with
antiperspirants.
it?
Well, they're very common nowadays. You don't have to go to the chemist and embarrass yourself. There's lots of the 72-hour. They went, oh, Mitcham, yes, someone uses that. I'm going to have a go at that, and I'll come back if it's not a problem. Right. She asked if there was something apart from Botox. I wonder if she'd had it for something else.
Okay, last case. This is from Vincent van Porten, who's a salivary gland surgeon in Belgium. So 69-year-old, non-smoker, no alcohol, some comorbidities, and she presents with a 2 to 3 month history of pain on swallowing and left-sided otalgia. And on examination, the left tongue base had a hard elevated tumour, no lymph nodes. So she has an MRI of her neck, which shows a left oropharyngeal tumour at the base of the tongue. And he performed an ultrasound of the liver and CT thorax with no mets, showing no mets. Okay. So what would you do next? Nick, what would you do next with that patient?
So
So you've got this
We've-
tongue
we've done
base lesion.
we've done our imaging, so we need to get a biopsy.
Yeah, okay. So panendoscopy showed a hard 4 centimetre tumour in the left tongue base. Okay. And so they use a lot of frozen section there, interestingly. So frozen section. And the sample was compatible with pleomorphic adenoma or an adenoid cystic cancer.
There's a problem with frozen sections, you see.
Exactly. So, treatment. What do you think, Nick?
Well, we've got the definitive histopathology back.
So, let's say it's adenoid cystic. So, how would you treat that? So, I brought that up because adenoid cystic can occur anywhere in the upper airodigestive tract. It's not very common. I don't think I've ever seen one in the tongue base. I've seen them in the larynx, I've seen them in the nasopharynx, the sinuses, but I haven't seen a tongue base. Have any of you guys seen a tongue base?
We've
I've
had
got
one.
You have?
I've got
Have
one.
you? Okay. So what would you do?
Post-radiotherapy, I think.
What's the
Delayed.
principles of treatment, Nick, for it?
Yeah.
So wide excision, and I'm not going to get into robots and exposure. We can debate that if you want to, but wide excision, probably with some form of reconstruction.
Okay. So you had a hemiglossectomy, selected net dissection, and free radial form reconstruction. Would you agree with that, Neil? Is that what happened at your centre?
Yes, it would be. I think the tongue base, obviously, this is a different beast to SCC, but it still needs a wide excision. I think we'd be very keen to get them pre-treated swallowing-wise, voice-wise. They need to go into this with a good understanding. I mean, hemiglossectomy is interesting. That looked quite far back. So that's going to be a big defect at their tongue base. And they need to know that they might well, especially if they're going on to get radiotherapy afterwards, that they're going to have problems with their swallowing. They might be peg dependent, they might be aspirating, and you might get significant problems down the line from that. So we might well be going slightly more aggressively with that, and bear in mind that if they're struggling beforehand, they might need even more doing, might end up with a trachea, that sort of thing.
So I think from the treatment point of view, with adenoid cystic outside of the salivary glands, in the airodigestive tract, generally, I think for the exam, if you stick to treating them a bit like a squamous cancer, you're probably quite safe.
I've got two tongue base, one mucoepidermoid and one adenoid cystic that we've done hemiglossectomies on. We did both of them transorally and didn't put flap in either, and they're swallowing normally, and they're free of disease, so they can be done transorally.
Okay. So the final pathology.
I know a lot of it because when Vin talks about doing his stuff at the tongue base, and they do that, obviously his recon transorally as well, and he seems to get really good outcomes with that.
Yeah.
But that needs a recon, whatever you do it with.
No, it didn't.
That
one
one
does.
did.
If you can do a hemiglossectomy, so you're not going across the midline, you don't need to put anything in.
So it was a 4 centimetre lesion up to the midline.
Yep.
So to get a margin, bearing in mind the tongue base will be no more than sort of 5 centimetres. There will be a huge defect there. I do a lot of transoral laser resection of tongue base tumours, but that particular one there, I would be opting for reconstruction.
If you're cutting up to the midline, so your resection is going to be the same. So if you're cutting up to the midline and for your margin, you still don't necessarily. It depends on how far. You can still take 2/3 of the anterior tongue and not get a margin.
But that's up to that region's up to the midline. So.
But then you're doing more than the hemiglossectomy. Well, you're talking about if the resection is the same. If you can cut to the midline and get your margin, well then you just do a hemiglossectomy. You don't need to reconstruct. If you need to take more than the midline, well then you definitely do.
Okay. So there's some poor prognostic features: perineural growth, close margin, positive lymph nodes. Bernie, what do you think? Do you think need some further treatment?
Absolutely. I mean, as I said in my talk, I would always advocate giving adjuvant radiotherapy irrespective of whether margins are clear. Because I think the other one is histopathological types as well. And if there's that solid component, that tends to be a worse prognosis, but won't change what we do. I feel the patient should still have radiotherapy. The question will be what nodal levels the lymph nodes were positive in, if there was in this particular case. And then obviously defining where you need to give the higher dose of radiotherapy, but treat the rest of the neck electively as well on the
And how far across would you go? Bearing in mind that the tumour is right up to the midline.
Yes, so we would use the details from the post-op histopathology, but also the imaging pre-op imaging as well, and use that to define it. But make sure, depending upon where margins were close or clear, then bespoke the plan for that arrangement.
Okay. So that's a question for you guys. How long do you follow up salivary cancer patients in your clinics?
Yeah, for something like this, they're lifelong, really, I think.
Nick?
Yeah, exactly the same.
Traditionally, it's been 10 years, but it probably should be lifetime.
Lifetime. Okay, so it's not the usual 5 years.
Yeah,
Keep following them
but
up.
I think the important thing on that is that it doesn't need to be done like we do for squamous cell carcinomas. The intervals can be longer.
Yes.
And I think more importantly, it's about explaining to the patient why we're doing that, and that's because we aren't able to say at 5 years there's a very high chance now you're cured, and the patients need to be aware of that. But usually patients will represent themselves back when they develop a cough or feel a bit more breathless.
So in Belgium, and Vincent's a very well-known surgeon, they do annual chest X-ray on all their malignant salivary tumours. Do you guys do the same?
No.
Yeah.
No, I
Why?
don't. I don't know why.
Yeah.
But because the chest metastasis is what you're worried about, aren't you?
But you'll find them, and the patient will just live with the knowledge they've got metastases for a lot longer, when it might be another 20 years before they actually die. And I think we're increasing the morbidity in our patient group by the anxiety if that happens.
Okay, fair enough. So he developed some abdominal pain. Are you concerned? That's a rhetoric question, really. Sadly, liver metastases a few years afterwards. Okay. All right, that's it. I think it's 5:30. So thank you very much.